Good afternoon, everybody. I think we're going to get started. So we have a debate this afternoon between frenemies, neoadjuvant versus perioperative IO for resectable stage 2 and 3 non-small cell lung cancer. For those of you who don't know our speakers today, this is a big deal. This is like watching the Roland Garros finals between Yannick Sinner and Carlos Alcaraz. Two giants here talking about the subject. For the Americans in the room who don't watch tennis, it's like a debate between North Carolina barbecue versus Texas barbecue. It's a big deal.
Oh, well.
So it's my pleasure to introduce Dr. Tina Cascone. She's a thoracic oncologist at MD Anderson in Texas. She's an oncologist and a scientist. She's the PI of multiple. She's been the PI of multiple trials, including NeoCOAST, NeoStar, and Checkmate 770. And she will be perioperative.
Thank you so much. It's wonderful to be here again. So thanks to John and Norman for having me. It's wonderful being in Montreal. So yes, this is a great event, and I hope that you all will agree with me that the perioperative approach is something that we all should consider for most patients. And I'll tell you why. And don't believe to any word that Dr. Forde is going to try to use to convince you otherwise. So these are my disclosures. So in 2025, for patients with resectable non-small cell lung cancer without actionable genomic alterations for which we have targeted therapy in the context of standard of care, or with IO sensitive AGAs, we have, thankfully, 3 different treatment approaches. We have the neoadjuvant chemoimmunotherapy followed by surgery with an FDA and EMA approval based on the Checkmate 816 with different conditions based on the PD-L1 according to jurisdictions. We have the adjuvant treatment, so the classical surgery up front, followed by chemotherapy and immunotherapy based on the Empower 010 and the PEARLS trials. And then we have the perioperative approach, where we have up to 4 cycles of chemoimmunotherapy, followed by surgery, and with the continuation of immunotherapy in the adjuvant setting as well, approved by FDA at EMA with different agents. We have the durvalumab, the pembrolizumab, and nivolumab. And I want to emphasize that today, for the sake of time and for the sake of the data available, I'll focus with, on some trials versus others, but the results for the perioperative approach, with some differences in maturity of data, are pretty much overall overlapping. So let's talk about the biological justification of why perioperative. So first of all, if we think about the neoadjuvant approach, so delivering immunotherapy prior to surgery, can give us the opportunity to have a better priming with an effective T-cell activation. We have a shorter time to initiation of IO when the tumor is still in place with lower clonal resistance and theoretically a maximal tumor antigen burden. And we can induce maximal response up front, especially when we combine immunotherapy with the cytotoxic therapy. But we have a short IO exposure if we stop the immunotherapy treatment before surgery. For the adjuvant IO, we can have a sustained killing of micrometastatic disease, especially after surgery when we have, as been demonstrated, an immunosuppressive environment. And we can try to combat that tumor PD-L1 mediated resistance. But we have a longer time to IO initiation in this setting. So the perioperative immunotherapy combines the benefits of both the neoadjuvant and the adjuvant immunotherapy. We can give immunotherapy throughout the entire surgical setting. We can control the relapse by this approach. We know that MRD is a major source of recurrence. And remember that our patients tend to recur, pretty much in the first year and a half after surgery. So perioperative IO will target that window. So the goal of anti-cancer treatment in this setting, it's okay to be humble, but we can be bold and say we want to induce cure for these patients, for all our patients. And from the data that we've just seen from neoadjuvant chemoimmunotherapy from Dr. Forde, and Dr. Spicer as well, at least 50% of patients, 51%, if you look at those curves, will experience disease relapse at 5 years after neoadjuvant chemo plus nivolumab only. If you ask your patients, once they have tolerated treatment well, would they choose to have a more intensive versus less intensive therapy? I would tell you that perhaps the vast majority will tell you that they want to continue treatment if they tolerate it well, and they want to be as intensive as possible if they can endorse that treatment. And we as physicians prefer to choose among multiple options because we can tailor these options, right, to our patients based on needs, logistics, functional factors, anatomical factors, social factors. So if we look at the randomized clinical trials that we have right now, and perform exploratory comparisons, we know that neoadjuvant and adjuvant may be a more effective treatment approach than neoadjuvant or adjuvant alone for resectable non-small cell lung cancer. So with this in mind, when I was preparing this, I thought, why did I put myself into this? The answer seems to be pretty straightforward here from a clinical perspective and from a biological perspective. So I went back and thought, what happened here? And so I have to tell you that John, Patrick, and I have a chat. We talk very, very often, sometimes multiple times a week. And we share a lot of things, successes, defeats, disappointments, joy. And so John was sharing with me and Patrick something and telling us that he was so happy about this. And then he said, by the way, would you guys be upset with me if I had the two of you debate each other on the neoadjuvant peri-op thing, or would you like me to avoid that for the ELIXIR program? And so this is the answer. Tina will destroy me. But I will valiantly do battle. And John goes, I'd watch that. Okay, then, we will call it the frenemy debate. Well, I heard the word on the street is that she can hold her own pretty well. So yes, let's see what happens. So neoadjuvant and perioperative immunotherapy are superior to adjuvant in other cancers. We are very well-known breast cancer mouse models about 10 years ago published by Michelle Tang, the Australian group, where you can see that single and combined dual immunotherapy is superior in the adjuvant setting as compared to adjuvant setting at curing mice. And we know from Sapna Patel and the SWOG group that perioperative, so neoadjuvant plus adjuvant pembrolizumab, improves outcomes as compared to adjuvant pembrolizumab alone in the SWOG 1801 in melanoma. We also know, and these are purely exploratory comparison for the sake of this discussion, that neoadjuvant or perioperative IO therapy is superior to adjuvant IO. Also, if we look at the perioperative data on the right from the Keynote 671, and we look at the Keynote 01 with adjuvant DFS. Theoretically, DFS should be better than EFS, right, just by definition. So if you look at these curves, you can make a conclusion. Now, how did we get to administering immunotherapy for a longer period of time being better? Let's start off from the metastatic setting, Keynote 189. We give up to 4 cycles of chemoimmunotherapy, 4 to 6, and then we continue with maintenance immunotherapy, and you can see these curves. From the Checkmate 153, PFS is improved with continuous versus 1 year fixed duration of immunotherapy for metastatic non-small cell lung cancer, 52% versus 31% PFS at 2 years. And then what about in the earlier stage setting, so unresectable, Pacific, we give 1 year of durvalumab, anti-PD-L1 therapy after concurrent chemoradiation therapy for patients who have unresectable disease, and you know from the 5-year outcomes what the results are. And then even earlier, in the early stage, locally advanced resectable disease, we had one of the most famous trials for non-small cell lung cancer, one of the most important pilot studies from Patrick Forde and colleagues at Johns Hopkins, as well as Memorial Sloan Kettering, where we had an MPR, major pathological response, of 45%, pretty unprecedented, and PCR 15% for patients who received only 2 cycles of neoadjuvant nivolumab with resectable disease. And you can see the beauty of the translational work pre and post therapy with an influx on CD8, PD-1 positive, so antigen experienced immune cells to really try to defeat, right, that immune resistance mechanism. So he said he was going to battle. So I did go back and look at a little bit of history. And you can see that Ireland has a fantastic history. And so I was like interested in the big battles and the Vikings. And I saw that Brian Boru was the last High King of Ireland. And I thought, it looks really like Patrick. Let me put them side by side. And Patrick Boru Forde is the High King of Neoadjuvant IO. He's also the High King of Twitter, and really the pioneer of the neoadjuvant work. However, if we give only 2 cycles of neoadjuvant nivolumab, you can see from work published by Dr. Forde and colleagues that after surgery, the frequency of peripheral T cells that are tumor-specific will drop. So perhaps 2 doses of neoadjuvant immunotherapy alone might not be adequate to sustain T cell activation. Now, Dr. Forde continued with this triumph. He led to the approval of the chemotherapy plus nivolumab with the Checkmate 816, approved by FDA and EMA for patients with resectable disease. We all know about this data with the PCR being improved, almost 25%, here 24% for the 816, with improvement in EFS. And just 2 weeks ago, he won another battle, the ASCO annual battle 2025, with the improved overall survival at 5 years from these trials. That, congratulations to Patrick, John, Mariano, and the entire team, was published simultaneously, New England Journal of Medicine, the 3rd one for Dr. Forde, so definitely a warrior. So you can see the data here. I'm not going to spend much time. You've seen the data just 2 weeks ago and published. 5-year overall survival with only 3 cycles of neoadjuvant nivo plus chemo, 65% versus 55%. So we have a 10% improvement. And you can see also the updated EFS on the right, 49% versus 34% with chemo alone. And so let's just put things in context, just for pure exploration. I think that if you look at the 5-year overall survival data with neoadjuvant nivo plus chemo, the data that is the closest in terms of maturity, although we still have a median follow-up for the perioperative pembro of 36 months or so, you can see from the curves that things are very similar overall. I think with maturity, there is a lot of censoring in the 671. We'll see whether these curves separate even more. The hazard ratio is identical. But again, different population patients, different trials. Now, if you look at the Checkmate 816 EFS at 5 years, that's the only thing that I can compare with the 70-70 with the overall similar follow-up, shorter for the 70-70, 41-month, presented right at ASCO by Dr. Provencio on behalf of the team. You can see that if you calculate in an exploratory manner the 30-month EFS from the 816, you can see that things are very similar, right? 60-65% with chemo-nivo as compared to 61% with the perioperative approach, and 40-45% with chemo-nivo neoadjuvant only as compared to 43%. So if we look at the overall population with the neoadjuvant and the perioperative approach, we can make the argument that things are overall similar. But what is the data that has the exact 5-year overall survival at this moment in time is the Nadim data. The Nadim data just published a few months ago, end of last year from Provencio and colleagues, only look at stage 3 patients. And so you can see here that the 5-year overall survival in the intention to treat population is 70%. So overall similar to what we've seen in the 816, where we have stage 3A. So this is specific curves for stage 3A presented by Dr. Forde and published by Dr. Forde. If we remove the 5 patients that were censored in ADIM and who died from a non-lung cancer-related causes, we get to an OS of 82.2%, which is pretty good for this population and numerically higher than what we see with the Checkmate 816. Remember, Nadim, the old Nadim 1, had chemo-nivo in the perioperative setting for 1 year after surgery. And so if we look at the patients who were able to receive at least 50% of the adjuvant planned cycles and did not have a PCR, you can see a pretty nice improvement. You can see the separation of the curves. So that tells us that there is a population of patients that definitely deserves to enjoy immunotherapy for a prolonged period of time. You have seen this data this morning by cycles. Here you can see the curves for patients with stage 3 N2 and non-N2 from the Checkmate 70-70 perioperative nivo. These curves are quite telling. You can see that the patients with a well-known poor prognosis do very well with the perioperative approach. with an hazard ratio of 0.46 for the stage 3 and 2. And if you look at the single and multi-station, 0.49 and 0.43. So we hope that these patients really at your tumor board should be considered for perioperative treatment. Now, if we look at the outcomes by PD-L1 expression, you can see that from the CheckMate 816 at 5 years, pretty much overlapping 53%. And if you look at as well known in the PD-L1 positive disease, we have the vast majority of the benefit with only 3 cycles on neoadjuvant chemoimmunotherapy. And surprisingly, we have seen in the OS from the Keynote 671 that there is a lot of censoring, but in the PD-L1 negative, although in the EFS we see benefit from a perioperative approach, I think we still need to see what happens in this population of patients. And what about the PCR? So Dr. Forde showed you here the 5-year OS and EFS. I think it's very clear that if you achieve a PCR, you do well, regardless of the treatment. If you don't have a PCR, you still do better by getting neoadjuvant chemo plus nivo. But please look at the separation of the curves in an exploratory manner. If you look at Keynote 671 and 77T, definitely a larger separation, so perhaps a better benefit by administering perioperative immunotherapy for patients who do not have a PCR. And so John Spicer here, another guru of Twitter or X, XTRIO really helps when there's disease left behind. And so Dr. Halmos goes and says that we argue about cross-trial comparisons, but carefully comparing 816 and 77T would be the most acceptable one to address this key, no? And so Dr. Forde and I and the team did so, and Dr. Forde very proudly presented this data at the World Lung Cancer Presidential Session last year with an individual patient-level analysis between the 2 trials that have the same agents, different population with very, very similar follow-up to answer the question, which patients might benefit from adjuvant nivo following neoadjuvant nivo plus chemo and surgery. We do understand and do acknowledge that this is a purely exploratory evaluation that should be taken with caution. However, we applied some very statistically sophisticated propensity score weighting analysis to really try to align the population of patients in terms of characteristics. And so you can see here that with all these propensity scores applied, there is results saying that perioperative nivo should be favored compared to neoadjuvant nivo only, with an hazard ratio by weighted AT of 0.61, weighted ATT 0.56, and unweighted 0.59. And this is comparing the patients who have received neoadjuvant treatment, have gone to surgery, and they have to receive at least 1 cycle of adjuvant therapy. But if you look in red, there is a benefit or a trend toward a benefit with an hazard ratio of 0.82 for perioperative nivo, even for patients that received or didn't receive adjuvant treatment. What about PCR and non-PCR? You can make the argument that with PCR, especially with the data that Dr. Forde will show us, that patients can be cured and perhaps there is no additional treatment needed. But remember, PCR doesn't mean cure. And in non-PCR patients, you can see definitely a trend favoring perioperative chemoimmunotherapy as compared to chemotherapy alone. You can see a trend favoring perioperative immunotherapy in PD-L1 negative population, so I'm not sure why we're continuing this debate, but you can definitely see the separation of the curves. And safety. Dr. Forde showed us that there is really no differences in the safety summary for the analysis population if we think about discontinuation of treatment because of AEs, of treatment-related SAEs, with percentages that are overall overlapping between the perioperative approach and the neoadjuvant approach. And so someone, I'm not going to say who, challenged this and said, well, you're actually looking at the wrong population of patients. And Dr. Forde very, very battled there and incorrect. This is absolutely a correct analysis to do if we want to look at the benefit, the potential benefit of adjuvant nivolumab after neoadjuvant and surgery. And he mentioned that with the caveat that this is an exploratory analysis, these results might inform the potential benefit and the clinical decisions in our day-to-day practice. There is really no declining of quality of life according to all the data presented from the perioperative trials. You can see the data from Dr. Spicer, just published a few months ago on The Lancet, with really no change in the quality of life overall with the perioperative approach, no significant change from the Aegean trial, and really less time to deterioration and the presence of symptoms from the Checkmate 77-2 when we have perioperative chemo-nivo. And as I'm closing out, a really true effort from Dr. Peters and colleagues just published, I think, 1 week ago or so. So a true network meta-analysis of EFS that does perform direct and indirect comparisons across all the neoadjuvant and perioperative IO trials published, which is Checkmate 816 only, and the rest of the perioperative, including the rationale and the Aegean, that many other meta-analyses are not considered. And you can see from the boxes that there is a trend when you do direct and indirect comparison favoring perioperative chemoimmunotherapy as compared to neoadjuvant chemoimmunotherapy overall and in patients without PCR. You heard this morning why this is important as a perioperative approach, because it gives us the opportunity to intensify therapy, gives us the opportunity to test novel regimen pre-surgery with continuation of therapy after surgery. You've seen the data from the NeoCOAST-2. Bertrand mentioned this data this morning in detail, so I'm just going to tell you that with the Dato-DXd, we have PCR that it's superior to what we've seen in historical control and an unprecedented MPR. And so in conclusion, we need to really think about the fact that the ultimate goal for our patients is the cure. For all groups of patients, even the patients who are with PCR might relapse. So perioperative immunotherapy gives us the strongest biological and clinical rationale to achieve this goal, especially if there is no really an issue with toxicity and with quality of life. We can tailor treatment specifically based on biomarker. We have the NCI Insight and the ETOP abduct lung that will look at these approaches in PCR or non-PCR. And then perioperative immunotherapy, as I mentioned, can form the foundation for building a novel and more effective combination. And now we have escalation of therapy. You also heard about these trials. We have the INTERPATH 002 led by Dr. Spicer and colleague, a pure adjuvant vaccine-based approach. And then we have the INTERPATH 009 for non-PCR patients who will receive a personalized vaccine in the adjuvant setting after neoadjuvant chemoimmunotherapy with the pembrolizumab or with pembrolizumab alone. So with this, I want to tell you that I am so grateful for being able to be doing this debate. There's been 10 years of friendship and collaboration with Patrick and with John. I have a few snapshots here. This is Montreal 2023. We went to the F1. I've done a lot of webinar with Patrick where we have so much fun and we learn from each other. And now we have Sockless Spicer here. This is Dr. Spicer with no socks presenting overall survival at the ESMO 2023. And this is from Dr. Kingford, not me. We have Johns Hopkins visit in Annapolis on the lake. It was a beautiful tour all together with Atosha, Mariano, and the entire team. And then speaking of productivity and successes, it's very nice to see that we share grants and awarded and unawarded publications, and it's very nice to see productivity with new babies and haircuts that need definitely an improvement from Dr. Forde on their babies, as he mentioned to us. This is St. Patrick's Day, and thank you so much for having me.
Wow, that was very good arguments. It's going to be very difficult for Dr. Forde to counter-argue. So the next speaker, again, does not need an introduction, Dr. Patrick Forde, world-renowned, famous thoracic oncologist, perhaps known best for the Checkmate 816 study. So really not much of an introduction needed, maybe more on a personal note. He probably does not remember that, but we've met a couple of months ago as we were at BTOG, and he was explaining to me how we have to put vinegar on fish and chip. And I'm a bit embarrassed to say that, but I looked at him and I said, "You look familiar. I feel like I've seen you somewhere before." And he gave me a very humble response. He says, yeah, you too. My name is Patrick Forde. And so thank you for being here. So the reason why I'm saying this is maybe he's just playing the underdog by telling Tina that he's going to get destroyed. And so we'll see what he has to say.
Yeah, thanks very much. And I might as well just stop now, I guess. But and just to point out, the original tennis battle of the sexes was Bobby Riggs against Jean King, and Bobby lost very heavily. So I think I'm going to be hammered here. These are my disclosures. And just to mention, so Spicer has put this up, but this is not fair. So Dr. Cascone obviously has style, a sophistication. This is her at ESMO. I didn't get a good picture, unfortunately. She had this extremely sophisticated pantsuit, I think it was, Tina.
Yes.
But that's her. And there she is bringing that European sophistication to Texas. And here is me. So go easy on me, okay? So I thought I'd start with a very unbiased CME-focused question. Which of the following treatment approaches is associated with no discernible increase in toxicity and a 10% improvement in survival at 5 years? So I'll leave that with you for a minute. Okay, maybe for 5 seconds. So these are the overview. So a phase 3 immunotherapy trials in resectable non-small cell lung cancer. I see Tina didn't get into the adjuvant debate. Somebody who will remain nameless mentioned that the adjuvant data, I think, are a pile of trash. So about 15 minutes ago, so does someone in our group. But so we'll focus on the neoadjuvant and the perioperative studies. And these are the regimens which are approved in the US. They're not available everywhere. So many countries outside the US, they're not available. So Checkmate 816, I'm not going to go through this, but the impact of it, I think, is significant. And it's not really related to me. It's related to all of the investigators and patients who took part in it over the years. But these are some of the numbers. 3 doses of treatment improved pathological complete response from 1 in 50 patients to 1 in 4. Patients who have a PCR are effectively cured of their cancer. Now, we know that 7% of patients in Checkmate 816 had a relapse of their cancer at 5 years. But one of these patients had an ALK fusion and was still alive in an ALK TKI at 5 years. And 2 of them, they had blinded independent review relapse, but did not receive any further systemic treatment for their relapse. So the assumption, or at least my assumption, is their oncologist didn't agree with the blinded independent review, or perhaps they got definitive radiation without systemic therapy. So effectively, these patients appear to have been cured. It's also directly responsible for curing 1 in 10 patients with resectable lung cancer, irrespective of PD-L1. And if you have a PD-L1 positive tumor, 1 in 5 of those patients who have surgery will be cured if they get neoadjuvant chemoimmunotherapy because of those 3 doses of treatment. And as I mentioned, and I would dispute this a little bit with Dr. Cascone, there is no measurable increase in toxicity compared to neoadjuvant chemotherapy in Checkmate 816. The data from the perioperative trials is a little bit more mixed. So here we have the final overall survival curves. You'll see here this 10% benefit at 5 years. The hazard ratio is 0.72, which has been pretty stable. We did just make a positive p-value or a significant p-value. I think 1 or 2 patients, one way or the other, might have pushed it to be an inconclusive study, but maybe it was meant to be. But when we switch from overall survival to lung cancer-specific survival, we see a different story. There are 10% more patients alive in the lung cancer-specific survival data compared to the overall survival. So that means 10% of patients in the chemo-nivo arm had died from non-cancer causes by 5 years. And this is something we don't talk about a whole lot in these debates. So these patients we see in clinic, and we saw it in our MDT with comorbidities, with raised BMI, previous cabbages, all of these comorbidities impact on their long-term outcome. So when we talk about adjuvant, neoadjuvant, perioperative therapy, we have to factor in all of those things. And as well, the key thing to think is of those 10% of patients, if you gave perioperative treatment, they would have spent a year of that time they were going to be alive receiving systemic treatment. We also see with Checkmate 816 that overall survival favored neoadjuvant chemo plus nivo in almost all of the groups. Even in the PD-L1 negative group, there was the hazard ratio was on the left of 0, or the left of 1, though less significant. So here to summarize, at 5 years, 10% of patients who received Nivo chemo had died from non-lung cancer-related causes. There were no cancer-related deaths between year 4 and 5. So if you get to year 3.5, 4, it's very likely you've been cured. And that's from that 3 doses of treatment you received 3 years before. And with an extended course of 1 year of immunotherapy postoperatively, or up to 1 year, which for some patients will be up to 25% of their remaining lifetime, really improve outcomes for that group compared to just those 3 doses of therapy. So here we look, and we've seen some of these comparisons from Dr. Cascone. I might point out she did mention several times there were very similar hazard ratios across all these trials. So she was kind of reinforcing my point to a degree. But in Checkmate 77T, we see that the EFS at 2 years was 67% with a hazard ratio of 0.61. Checkmate 816 hazard ratio the EFS at 2 years was 64% with a hazard ratio of 0.63. It would be hard to put a wafer in between those numbers, but this was from 3 doses of treatment in Checkmate 816 versus, I think, 16 doses in 77T. Moving to Keynote 671, which Dr. Spicer presented without any socks at ESMO a couple of years ago. So this is a more selected cohort, I would point out as well. These are patients who were eligible for cisplatin. So we noted in our MDT, several patients would not have been candidates for cisplatin-based treatment, at least in our discussion. There were also patients in general who were able to undergo surgery and then receive up to 13 cycles of adjuvant therapy, which is not every patient we see in the clinic as well. In terms of the treatment disposition, we talk about perioperative treatment, but an important point is that when we see that patient at the start, we might talk about giving them a year of treatment, but the reality is probably only about 30 to 50% of them will complete out the planned course of treatment if you talk of giving perioperative treatment, and at least 30% of them won't get any adjuvant treatment. So we're really not talking about perioperative, we're talking about a mixture of neoadjuvant and perioperative in these trials. Now to look a little bit about the adverse event question. So these were adverse events which occurred during the surgical treatment phase in Keynote 671. And there is a measurable difference. 4% of patients in the Pembro plus chemotherapy arm over the placebo arm had serious or high-grade toxicity. Now, since you're giving placebo in one arm and Pembro in the other, my assumption is that 4% of serious or high-grade toxicities must have been related to Pembro. So it's not a free lunch. Whereas in the nivolumab plus chemotherapy data, if you look at Checkmate 816, the numbers are actually lower. Now, they're not statistically different, but they're lower for almost all of those, 45%, all grade 3 and 4 events in the chemo arm, 43% in the Nivo chemo arm. Treatment-related adverse events, 38% in chemo alone, 36% in Nivo plus chemo. So you couldn't argue there's an increase in toxicity here. You could argue there's an increase in toxicity with the perioperative regimen. And let's look at the populations. So here, to be fair, it is a more advanced disease population. So in the perioperative trials, most of which, except for Aegean perhaps, which excluded pneumonectomy, most of 77T and 671 included up to stage 3B cancers, which are more locally advanced. However, Checkmate 816 had a lower number of PD-L1 positive tumors. And PD-L1 positivity, as has been pointed out by Dr. Cascone and by myself and others, is a very strong predictor of outcomes so far, at least with neoadjuvant or perioperative treatment. But the results are not that dramatically different. So in Checkmate 816, we have 2-year event-free survival of 65%. Similar in 77T, 65%, Aegean, 63%, and Keynote 671, a little bit lower at 62%. So even though these metrics you might assume will equal out, that extra 13 cycles, 14 cycles, whatever it is in the adjuvant setting, is not dramatically improving outcome for these patients. Now moving to PCR. So if PCR occurs after just those 3 doses of treatment, so that portends 88% 5-year event-free survival and a 95% likelihood of being alive at 5 years without adjuvant immunotherapy. So what does adjuvant IO add after neoadjuvant IO? I will agree with Dr. Cascone that the outcomes for those patients who don't have a PCR are poor. These are like the outcomes we would have seen for unselected lung cancer perhaps 10 years ago, undergoing surgery. And she did point out this presentation, which has my name on it, apparently, and which I reportedly presented. Some people say I presented. It sounds like someone from south of here. But here we have perioperative nivolumab versus neoadjuvant nivolumab plus chemotherapy. Now, one of the issues which has been pointed out to me exhaustively by many people after the presentation was that the 77T analysis here was restricted to those patients who had surgery and received at least one dose of adjuvant nivolumab. So that excludes about 20 to 30% of patients who probably have the poorest prognosis, whereas in the CheckMate 816 study, it included everyone. So you didn't have to start any form of adjuvant treatment. You were in this analysis. And here we see, despite that, for those patients with PCR, there's no practical difference. The hazard ratio obviously does seem to favor perioperative therapy, but when you look at those curves, it's impossible to separate them. Now, perhaps for the no PCR group, who we agree has a poor prognosis, giving some further therapy, whether it's anti-PD-1 or whether it might be preferably something, so an improvement over anti-PD-1, PD-1 plus something else, maybe a targeted therapy, so it may improve matters. But does it have to be further PD-1 therapy? I would debate that. And then looking at PD-L1 expression. So no PCR is a bad prognostic factor, and PD-L1 negative tumors in this IO era is also probably a bad prognostic factor. And that's what we're seeing here again. Giving some further therapy versus nothing is probably better, but there has to be something better than just more of the same for these patients who are poorer prognosis. And also, show me the money. So this is mostly Canadian data, I believe, because the Canadians like to count their money, but this is looking at the incremental cost-effectiveness ratio per quality-adjusted life year for these regimens. So in CheckMate 816, with no selection by PD-L1, the cost per quality-adjusted life year is $32,000, whereas for perioperative therapy, it's $94,000. So this is almost 3 times as much. And there are ways we can address this, and this is one of them. I think the studies being led by Dr. Cascone, such as the NeoCOAST trial, where we look at new treatments for this disease, are really important. But this is getting back to basics, sponsored by AstraZeneca, run through ETOP in Europe, looking at randomizing patients after receiving initial neoadjuvant chemo plus durvalumab, and then having surgery, whether they have a PCR or not, they're further randomized then to either durvalumab or observation. And I think this will ultimately answer this question. I agree it will take a long time, but it's a key question which needs to be answered in the field. So why neoadjuvant only? So it's a really good treatment option relative to the other options we have. It's a short duration, low toxicity in terms of both physical, time, and financial toxicity, lower health system cost, and it may improve both surgical outcomes, and it definitely improves overall survival at 5 years. For at least 1 in 4 patients who receive neoadjuvant therapy, it'll be impossible to improve their cancer outcomes further, at least based on our current understandings of this. And patients with lung cancer are vulnerable to competing risks of morbidity and mortality. And is giving more than a year of therapy to someone who may have a median survival of 4 or 5 years, choosing wisely in this setting, where their multiple survival may not be due to cancer risk. So the evidence thus far, which I've presented, and Dr. Cascone pointed out, is modest and indirect, that perioperative therapy improves outcomes. It may do so for select subgroups. And finally, I would suggest to you it's not a good idea to argue with somebody who looks like this. So, okay. Thank you.
So that was really excellent. So we will have a panel discussion. Oh, it was good with the photo. It could help with the vote. Before we do the panel discussion, Jonathan told us a bit before we started that we didn't have anything any pointers or clickers for the voting system. So I guess we will vote through a clapping system. So we're starting with who's voting for Periop. You can clap.
Who did the best thing?
It's the table that is by.
And who's voting for Neoadjuvant?
Yeah.
What do you say?
I'm just a moderator.
Oh, come on.
I say take it out. I vote for surgery. Great.
I vote for surgery.
Thank you very much for really an excellent debate. Really, you stand up to your aura, both of you. So thank you very much for entertaining us and educating us. And I think we'll go on to questions. If we have the mic, please. Maybe I'll start with a question while we wait. Maybe to Dr. Forde. You talked about the non-PCR group and how maybe in those patients who may have residual disease, and I guess when we talk about the non-PCR patients, we're talking about not local disease, but maybe residual systemic disease. So how do you see the role of ctDNA clearance maybe playing a role in that decision-making fork? Or do you see a role for ctDNA clearance?
Yeah, I think so. The ctDNA data which we presented at ASCO, it's also predictive of outcomes. The problem was we didn't have data on a large number. We had it on about 25% of the patients, and it was a tumor-informed assay which has its own complications. I suspect in the longer run, ctDNA may be helpful in these scenarios. MRD, for example, in that post-operative setting. Because with the non-PCR group, you're always going to have residual tissue to sequence. The challenge is with the PCR group, the initial biopsy may not be sufficient for a tumor-informed assay, and then you have a PCR, so you don't have further tissue to sequence. But I think probably what ctDNA MRD needs to do is to advance as a field and become more facile in terms of use. And then I think we will adopt it. It's being adopted in the US, I think, pretty widely. Not so much in the rest of the world, but I think it will ultimately be helpful. But I do think that non-PCR group is a high-risk group, and it's definitely open for further investigation. I think in the short term, perhaps nivolumab or pembrolizumab or durvalumab is the best treatment we have for those patients, but we really should be trying to advance in that further in terms of either targeted therapy, say you had a KRAS mutation, or perhaps kind of modifying treatment further in that post-op setting.
Perhaps I can add, and I think this is just absolutely, on point. And we have seen also in the 70/70 as well as in the Aegean, and Patrick mentioned this many times in his comments and discussion, that really, if you don't have a clearance, right, after neoadjuvant chemoimmunotherapy, you have a very high chance not to have a PCR, almost close to 100%. And if you have clearance, 50% of patients or so will have a PCR, 50% will not. So I think that definitely there is even more subgroups, right, that even in the patients who cleared and might not reach a PCR, those are the patients with really a poor prognostic outcome that we need to definitely consider escalation of therapy. So across all the trials, it's definitely something that we have learned and keep learning. Many of us are now starting to do longitudinal, ctDNA, wherever we can, right? It's definitely no standard of care, but wherever we can. And then Patrick mentioned about the complexity of having a tumor-informed assay, right, versus a tumor agnostic and so forth. So I think those are all points that are very important as we think about tailoring these treatments, right, even in the context of future trials.
Dr. Blais?
It's not every day that we have the king and queen to ask a question to. I know this debate would be ended off on a tie, so what do you do when you expect a tie? You ask ChatGPT, and I was really happy that you showed Solange's meta-analysis, which allowed me to calculate the expected hazard ratio for a study comparing post-operative therapy to no post-op therapy. So the calculation was 0.92. So to do a trial to show 80% power of a 0.92 is 6,000 patients. Can we really do this study, or is there a way to maybe better select patients that are at really, really high risk of progression to study this further?
I think the latter, for sure. I mean, realistically, pragmatically, and impactfully, I think We don't have that amount of patience. We don't have that amount of time, right, to make that impact on society that really matters. So I think that learning as we're doing from all that we've done, and then understanding what are really the subgroup of patients. The reality is that the neoadjuvant approach is a phenomenal approach for who is going to achieve a PCR. And as Patrick mentioned, who is not achieving a PCR definitely needs to continue treatment, and whether that is going to be the same treatment or an escalation, even tailored based on additional, right, subgroups, whether you have a stage 3 and you're PD-L1 negative and you have ctDNA, so that's a subgroup of a subgroup. That's definitely something that I think is going to be much more impactful to address than, right, comparing standard of care options for an incremental gain, if it makes sense.
And I think, Norman, to add, the adopt lung is being powered off the non-PCR group, so it reduces the numbers quite a bit. But I think your calculation is correct. I've heard recently there's a trial being run, which will be so many thousands of patients, which you can run one of those trials, but you can't run 5 of those trials with novel agents, you know, so that's a big challenge. There's, just to give a little plug, there's a SITC webinar in a couple of weeks, which Tina and I are both involved in, which will address a lot of these issues. A lot of the decision-making on future trials is driven by the FDA's regulatory environment, unfortunately or fortunately, so it impacts global trial design. And I think that webinar will have representatives from FDA, from industry, and many medical oncologists. There's a separate surgical group who are addressing surgical issues.
Just a quick second in between, it's not a question. I agree with mostly everything you said. Just in terms of housekeeping, if you could take a minute or two at the end of the day, each of you, to help Tash and Angela, there is a QR code on your tables, a quick survey. You can scan from your phone just to make the next editions even better than this one. So if you have a minute or two, that would be very, very appreciated to give them the feedback. And that's it for me. Thank you.
This was awesome. It was a pleasure to watch. I'm not sure who won, but that wasn't the point. One of the things that's kind of striking with this new paradigm of care is that the most, if I'm understanding the data correctly, is that the most common form of recurrence now after neoadjuvant chemoimmunotherapy and surgery is actually local regional, more so than metastatic progression. Do you have any insights on how perioperative treatment may influence rates of local regional progression? Does that mean we need to conceptualize our escalation strategies accordingly, or maybe factor in predictions of which of the types of recurrences these patients may subsequently develop based on other factors?
Yeah, I think all of the above, John. I think if you look at the subsequent therapies across all the trials, I didn't want to have a slide 41 in my deck, but I did go and did take a look. Patrick showed this for the 816. You showed this, right, in the 671. And we have that even for the, the adjuvant data as implementing immunotherapy early on versus later. And I think it's pretty much consistent across the trial that you have a lower percentage of patients with progression, as expected, who have the need of immunotherapy as compared to the chemo alone. I have to tell you that it's true that the local regional recurrences are more often, but I actually see systemic recurrences that are very much oligometastatic. The brain lesion, right, that show up after the perioperative paradigm. So we don't have, to my knowledge, across trials, specific analysis to tell us with the perioperative approach across trials what are these trends. But I think you're absolutely correct. Do we need to tailor right treatment based on these relapses? I don't know. I'm not sure whether continuing the adjuvant immunotherapy will have to be tailored with also some form of radiation, right? If you think about the local recurrence. I mean, that's something that definitely should be experienced. It should be tested in trials.
Yeah, this brings me to the question I was going to ask as a radiation oncologist. As John mentioned, with most recurrences being local regional, what do you think is or will be the role of, and we know the previous lung art was a negative trial, kind of killed the port role, but there probably is, I believe, room for re-exploring, given that patients that have disease that is more and more advanced that are being operated, and now that the distant metastasis is more controlled, more local regional recurrences, do you foresee a role for adjuvant radiation? And should there be cases where, in fact, the adjuvant radiation should preclude over peri-op? And if there is a role for adjuvant radiation and peri-op, how do you see the sequencing, or what would be the future for that?
Yeah, so I think it's a really good point, because so in 816, there was a lot of radiation given postoperatively without systemic therapy, and I suspect a lot of that is SBRT treating solitary lesions, or perhaps dealing with solitary areas of recurrence. So I think there probably was effectively a lot of radiation given postoperatively. Now, we don't unfortunately have details, which I think would be very important for future trials to collect in that regard. But I think to John's point, I think the local control is going to have to improve, and I think we have to revisit assumptions that post-op radiation doesn't work in the pre-immunotherapy era. Maybe it works in the immunotherapy era. Maybe things like more novel techniques, use of SBRT, say for a single area. All these different approaches could be helpful, because the local relapse rate is still quite high.
And that's the same for the adjuvant setting. If you look at the Empower 1.0, among all the recurrences for PD-L1 positive patients, really the highest was the local regional in the atezo arm as compared to the placebo arm, and vice versa instead for the systemic relapses. I think the question there, and this is just out of an experience from last week clinic, a patient with neoadjuvant chemo durva, and then with an N0 disease to start, and then at surgery, a 6-centimeter tumor that had not shrunk whatsoever a little, an N2 disease that wasn't present on IBUS at baseline, a ctDNA negative, done before and after surgery, and an evaluation given the N2 disease despite margin negative by the thoracic radiation oncology upon my request for multidisciplinary academic consideration, not port, because this might preclude, not only based on the ART data, but this might preclude my ability to give radiation if there is a local regional recurrence. Right, so that's something that, this is just last Monday, so this is something that makes a lot of sense in terms of discussing these cases, right, in the multidisciplinary tumor board or multidisciplinary clinics, and again, revisiting the, radiation, but perhaps at time of recurrence, not necessarily as a port. But it's complex, definitely complex.
Maybe one more question, if that's okay. I'm curious to know your input as oncologists who are seeing these patients and evaluating them for these therapies post-operatively, with the kind of rise now of subcutaneous immune checkpoint inhibitors. Dr. Forde talked about, having these patients come for another year of their life to the hospital to get these therapies. Now we're hearing about patients potentially being able to inject these drugs on their own every 3 weeks or even every 6 weeks at home. Do you think that will have an impact on whether or not you decide to give these drugs in the future?
It's an interesting one, actually. So in Europe, a lot of the countries, they a subcutaneous version of an already approved drug doesn't have to go through the same reimbursement challenges. So they're actually pretty quickly available as soon as they're approved by the EMA, and we do use quite a lot of subcutaneous atezolizumab. And I think the other issue, so in the US in particular, there are concerns about reimbursement, because the drugs at the moment have to be given in the infusion center to actually be reimbursed, and they have to be bought by us. So there's non-medical challenges to them, but I think theoretically they could be a big advance, particularly if you do want to give long durations of therapy, or say you had a clinical trial which is positive 4 years from now, combining, say, durvalumab with a novel agent, where the novel agent is also subcutaneous. You would want a scenario where you could give that as an outpatient,
Yeah, I agree, and I think we all agree on the fact that there are some subgroups of patients who need to continue therapy in the adjuvant setting. Again, whether that's the same regimen or an escalation, that's to be determined. But if you have the opportunity to administer the regimen with much ease and, avoiding logistics and financial toxicity that can be relevant, that's definitely a plus. I actually have a lot of patients, and I do acknowledge, I'm in an institution when there is a lot of patient selection, or patient comes for a second opinion, and they want to go back to, their community to be treated. We get asked, even in the context of trials, can we get this therapy now as a subcutaneous injection and still be on the trial, right? Because I don't want to miss on the opportunity to be on a very personalized vaccine, but why do I have to get this treatment, even if it's just every 6 weeks? So even the patients now that, are knowing more and learning more about the treatments for their disease want to embrace, right, that. And we know the data is pretty much, across all the drugs, pretty much, overlapping and in alignment with the IV administration, so in terms of efficacy. So that's definitely, reassuring, and that's something that we all should push forward to continue to implement those in the new trials.
It's potentially more cost effective as well, because the pharmacy doesn't have to check it as much. It's an injection pre-filled and all this, so.
Great. Thank you very much, everyone. I guess, when we were hearing the clapping, it was perhaps a little bit more towards the neoadjuvant versus peri-op, but if we take into account Tina's style, it sort of balances out. So we'll say it's a tie. Thank you.
Thank you.